Hi, Heather. Your hair is so long. It's beautiful.
Good morning, everybody.
Good morning, Mickey.
Aubrey was having trouble getting in. Let's see if she made it yet. I think I'm the admin. Okay, we're just gonna wait just a second and allow, we've got 20 people logged in, including us, and we had about 40 people registered. But I just want to thank you all for joining us. I hate looking at myself so early in the morning. I know this is kind of a strange way to do the summit, and it's been really, feels kind of scattered. I miss being in person with everybody and sharing meals and stuff like we usually do. We get a lot of work done in those conversations as well as in the session. So I really appreciate you guys hanging in there with us and trying to do this in just this very different way. And hopefully next year we'll be able to be a little more back to normal. I think I'm just going to email myself the slides for now. But let me start off by saying welcome. Iswachi, Vikilo Sinsnas, Titlam Nusquayam. I'm Vikilo, I'm Jamestown Squalam. I'm also Bella Coola First Nations from Canada, and I am the Executive Director of the American Indian Health Commission, which is like my greatest pleasure is doing this job and working with all of you, and especially these two ladies here. Today we're going to share with you about the work we've been doing on tribal-centric behavioral health. And and I'm gonna step away and get some things going and have Heather and Catherine introduce themselves. Thank you. Heather, we'll go alphabetical.
Hi, good morning, everyone. Happy Monday. My name is Heather Erb. I am the legal consultant with the American Indian Health Commission. Glad to be here with you guys today.
Good morning, Catherine Akia. My name is Catherine Akia, and I'm a consultant for the American Indian Health Commission. It's good to be here today. I'm also a member of the Yakama Nation and descendant of the Dene. It's wonderful to be here, and I'm excited to share kind of what we've been doing in this work, and kind of give some summaries of some of the tribes that we've been talking to about this work. So I'm very, very excited to see where this has come from and where it's going. So looking forward to some questions too later. Hopefully we can use either the Q&A or unmute some folks if you've got some questions. Thanks.
And thank you. And we also have Lucy Mendoza from the Healthcare Authority to help with some questions because she's been a really great partner in all this work we're doing. Lucy, do you want to introduce yourself?
Yeah, sure. Good morning, everyone. My name is Lucy, and I work with the Healthcare Authority Office of Tribal Affairs. I'm not ready at all, so I'm turning off my camera right now. Glad to be here.
I thought I was ready till I saw myself.
You all look great.
And Aubrey was able to join us. I'm not able to make you organizer for some reason, Aubrey, but I made you presenter. So if you could pull up the slides, that would be great. And I guess I will monitor the chat box. And real quickly, just want to see who's here with us today. I'll just call your name and hopefully I can unmute you all. And if you can just unmute yourself and say who you are and where you're from, and that will help us with our presentation. So we'll start with Andrew Shugren. And it says that they're still all muted by me. So I'm going to go down and unmute you one at a time.
Good morning, everyone. Andrew Shugren. I am the Health Policy Director for the Dequalich Wellness Center up here in Anacortes, which is owned and run by the Swinomish Indian Tribal Community. And I've been involved in this work in various ways, and happy to get an update. Thanks.
Thanks for joining us. And we have Aubrey Gamble. Oops, there, I think you're unmuted. Sorry about that. Aubrey, are you able to unmute and introduce yourselves? No, because I've muted you. Okay, now try. How about Candy Rogers? Oh, Candy, I must have muted you and I was trying to unmute Godfrey. Try now. Kara McCoy. How about Carola Brenes? Do you all know how to unmute? And here, I'll try some. Yes, thank you. I'm feeling a little bit better.
My name is Carola Brenes, and I am a tribal prevention system manager for the Division of Behavioral Health with HCA. Thank you for having me.
Thank you. And then we have Cheryl Wilcox. Cheryl is muted by me and herself. Okay, now try Cheryl. I think I got it.
Okay. Hey everyone, this is Cheryl Wilcox. I'm with Healthcare Authority and I work with Lucy and work in the recovery support section supporting tribes. So nice to be here.
Thanks for joining us. And Christina Diego.
Can you hear me okay?
Yes, we can. Thanks for joining.
Hi, I'm Christina Diego with the Seattle Indian Health Board, and I am a member of the Colville Tribes of Washington.
Thank you. Welcome. Gina Skinner, I sent you a pin and you just have to put it in your phone and hit pound and we should be able to hear you. But we will move on to James Manuel.
Hello, James Manuel, a policy analyst with the Health Benefit Exchange and a member of the Colville Tribe as well.
Thank you for joining us. Jason McGill.
Hi, good morning, Vicki, Heather, Catherine,
Morning.
Jason McGill from Healthcare Authority. I'm Assistant Director for Medicaid Programs.
Thank you. Jen Olson.
Hi there, good morning. This is Jen Olson with the American Indian Health Commission.
Good morning. Jenna Bowman.
Good morning. This is Jenna Bowman, Washington State Tribal Liaison for United Healthcare.
Hi, Jenna. And Jesse Dean. I think he's back.
Yes, I am. Good morning. This is Jesse Dean, Tribal Affairs Administrator for the Healthcare Authority. Thank you.
Thanks for joining us, Jesse. Catherine Saluskin. Catherine? Oh, she has her hand raised. Can you unmute, Catherine? Maybe not. Kimberly Thompson, she says she'll be in and out, so I don't know if she's in now. Kim, are you able to unmute? Kim is the health director for the Shoalwater Bay Tribe. And then we have Lena Nashand.
Good morning. Thank you for having me. My name is Lena Nashand. I'm the Tribal Liaison for Medicaid Transformation at the Healthcare Authority.
Thank you. Linda Lauk.
Good morning. This is Linda Lauk from the American Indian Community Center and Good Heart Behavioral Health here in Spokane, Washington.
Good morning, Linda. And then we have Lisa Ray Thomas.
Good morning, everybody. Thank you. Vicki, you are a super ninja for sure, especially on a Monday morning. My name is Lisa Ray Thomas. I'm a member of the Tlingit tribes. I also work with the commission and am at the University of Washington Alcohol and Drug Abuse Institute. Thank you.
Thank you. And Marilyn Scott. Marilyn, or did I unmute you? Okay, good.
Good morning, Vicki.
Good morning. Good morning.
This is
Sorry.
Marilyn Scott, and the vice chair of the Upper Skagit tribe, and my family given name is Wichalitza, and I'm so happy that we have so many that has joined us today. Thank you.
Thank you. Then we have Melissa Livingston.
Good morning. This is
Good
Melissa
morning.
Livingston at the Healthcare Authority, Office of Tribal Affairs, and I'm a Muskogee Creek citizen.
Thank you. Michelle Alger.
Hello, good morning. My name is Michelle Alger. I work at Healthcare Authority in the Medicaid programs in compliance review and analytics, and I'm happy to be here. Thank you.
Thank you. Natalie Christofferson.
Good morning, this is Natalie Christofferson. I'm a member of the Cherokee Nation out of Oklahoma, and I'm the tribal liaison for Community Health Plan of Washington. Thanks for having me today, Vicki.
Good morning. Thanks for coming, Natalie. Then we have Ryan Keith. Ryan, did I get you unmuted? No. I'm not very good at this. There you go, Ryan. How about now? Nope. There we go. Yes, sorry. That was mostly me.
My name is Ryan Keith. I'm with the Division of Behavioral Health and Recovery at the Healthcare Authority.
Thank you for joining us. Sarah Gibba, is that? I hope I got you. Okay.
Good morning.
Good morning.
I'm interim clinical supervisor for Tulalip Tribes Family Service Adult Behavioral Health.
Oh, thank you for joining us, Sarah. How about Sasha Waring?
Hey, good morning. I'm a child and adolescent psychiatrist and the senior behavioral health medical director with Molina in Washington, and it's a privilege to join you today. Thank you.
Oh, thank you for joining us. And Sheena Bertel.
Good morning.
Good
I'm
morning.
Sheena Bertil, and I work in the Youth Behavioral Health area of the NADA Project in Spokane, Washington. I'm also a member of the Grobon Tribe of Fort Belknap.
Thanks for joining us, Sheena. And Summer Hammonds, welcome. I think this might be your first meeting with the bigger group.
Hi, I'm Summer Hammonds, Legislative Policy Analyst for Tulalip Tribes. We also have a group of leaders from Tulalip just because sitting on the platform of all of your guys' good work, we just want to be able to use that as a resource and all kind of pull together for what's best for our community. So thank you.
Thank you, Summer. Tara Piper. Are you still? I'm sorry, that's me again. There you go, Tara. Can you introduce yourself, or are you still muted? Nope, it's me again. I don't know what I'm not doing right. Okay.
My name is
Now?
Tara Piper, and I work for the section, I work for Managed Care Oversight for the Healthcare Authority.
Thank you. And then I see Raina has joined us. Raina, do you want to introduce yourself? I think I got you unmuted. Nope.
There we
Not
go.
sure.
I was pressing mute and unmute at the same time. We just kept muting each other.
This
right.
is your Monday morning entertainment.
Well, good morning, everybody. My name is Raina Pione. I'm with the Office of Tribal Affairs, Healthcare Authority, and I'm the Regional Tribal Liaison for Eastern Washington.
Thanks, Raina.
Thank you.
And John Okema, did I say that right? Are you able to unmute and introduce yourselves, or did I just mute you again? I know this is painful. I'm sorry. Yep, I muted you. How about now? Oh, turned your audio off. I'm not sure what happened there. And then I see Ed Fox joined us. Good morning, Ed. Let me see if I can get you unmuted. There you go.
Yeah, hello, Ed Fox, National Indian Health Board, and I'm always talking to Squaxin Island and other folks.
Thanks for joining us, Ed. And then we have, oops, AB Castillo. I think that's everybody. AB, are you able to nope, you aren't because I didn't unmute you. Okay, now maybe you can unmute. Nope. I think I'm clicking too many times, right? Okay. Clearly I need a lesson in that. Sorry, AB.
Hi, this is AB. Hi, this is AB. Hi, Vicki and everyone. External Relations Officer with Community Health Plan of Washington. Thanks for having us. Appreciate it. Thanks.
Thank you. And we have Veronica Smith from the Northwest Portland Area Indian Health Board. Dang it. There, I think you can unmute now, Veronica. No? Yeah? Okay.
Good morning. It's Veronica Smith. I'm a health policy.
Yeah, we can
Good
hear
morning.
you.
Great. It's Veronica Smith. I'm a health policy consultant with the Portland Board. Thanks, Vicki.
Thank you. So thank you all for joining us. Sorry that was so painful. Let's see. So we talked a little bit about who we are, and John Okima, I hope I'm saying that right, is the Tulalip Health Clinic, and his audio is not working. And same with Catherine Saluskin, Dinosaur. Computer won't let her speak. She is the Director of Yakima Behavioral Health. I got that right, I hope. So this morning we're going to talk about our work on tribal-centric behavioral health. And we did pull this term from the work that had been done in the past by the by IPAC, and the Commission's been a part of that work, and tribal leaders and DSHS and DBHR and Healthcare Authority, because it's a familiar term, and it kind of gets at the work that we're trying to do to make sure that the services that we're able to provide are tribally driven. So thank you for joining us. Next slide. And I want to do the land acknowledgement real quick. I don't know if you can pull that up. It was in my last email. So while she's doing that, it's important for us to do our land acknowledgements because, well, I'll say what it is, and that is kind of self-explanatory. I'd like to begin by acknowledging that we gather today. We are all on the ancestral homes of Indigenous people who have lived on these lands from time immemorial. Where I am in Squamish, that is the S'Klallam people and the Salish people. And please join me in expressing our deepest respect and gratitude for their enduring care and protection of our shared water and lands. New S'Klallam is S'Klallam, and S'Klallam means strong people. Thank you. Thanks, Aubrey. We're really testing our skills this morning. You wouldn't know we've been doing webinars for 8 years. This is what it looks like without Lou. So just a quick overview of our agenda this morning. Heather's going to talk about tribal jurisdiction and authority. I don't know if you were able to catch her presentation she did at Governor's Indian Health Advisory Council in August, but this will be really a high-level overview of that. We'll talk about the Indian Behavioral Health Act that passed this last session, about the Washington State requirements for being a designated crisis responder, or DCR, and then the proposed state regulations for tribal DCRs. I'm going to talk a little bit about the difference between a tribal and a non-tribal DCR. What is the need for behavioral health code, which is something we've been working on with some of you all who are on here. And then looking at how to map out tribal designated crisis responder services at your tribe, so at the tribal level. And then what are our next steps in this work? Thank you. Bless you. Next slide. So this is Heather.
Yes. Oh, hello again, everyone. Yeah, we just have a few slides here about tribal jurisdiction and authority to frame our discussion this morning, or at least have some of the fundamentals for everything that we do at the Commission, not just the subject of tribal-centric behavioral health. And we know that some people on the line today may be new to working with tribes and urban Indian health programs, and may not be familiar with some of the legal underpinnings of Indian law. So that's another purpose that we like to go over some of these fundamental principles. So first, it's important to know that tribes possess the inherent sovereign authority. And when we say inherent, that means what we're saying by that is it's not given by the federal government or the state government. It's something that sovereign authority is what tribes have possessed since time immemorial. And they have the sovereign authority to provide behavioral health services for their community members. And that would include providing preventative services, inpatient treatment, and involuntary commitment proceedings through their tribal courts. Next slide, please. And there's an abundance of case law. Supreme Court since the 1800s has recognized tribal sovereign authority. And the first principle, again, you can find that going back to Chief Justice Marshall. But here I have a case cited from the mid-90s that really emphasizes that the tribes have inherent sovereign authority over both their members and their territory. So it's not just over the land, but also over their members. And that power includes the power of regulating their internal and social relations. So making laws, passing their own administrative policies and procedures that affect the members on their tribal land, and also in some cases, even non-members on tribal land. Next slide, please. And I know we all know most of us here know that we're a public law 280 state, and that can make things confusing. And I'm only going to have 2 slides on public law 280 today. Sometimes we've done, together as a team, we've done presentations that are as long as 2 hours on public law 280 because it gets so complicated. But I think Vicki will be happy to hear that we're just going to spend just like 30 seconds really on it today. And just to remember, with public law 280, which was really, it's a shared jurisdiction in certain areas, certain subject matters with certain tribes where they share jurisdiction with state courts, but it's incredibly limited. So what does that mean for behavioral health? Well, it's really important to remember today just what it does not do, because that's where sometimes folks get confused and think that the state has more jurisdiction than it really does. Public law 280 does not remove a tribe's sovereign authority. So those last 2 slides where I was talking about tribes having sovereign authority over behavioral health on tribal land, if a tribe, even if they are a public law 280 tribe where they share court jurisdiction with the state court, that does not remove the tribe's sovereign authority to provide those services. And secondly, it does not grant authority to a state, to Washington state, to regulate civil activities in Indian country. And then lastly, public law 80 did not remove the criminal or the civil jurisdiction of tribal courts. It's shared. So even though a state court, in again, very limited situations, may have jurisdiction over a tribal matter, it is a shared. So that means that the tribal court at the same time can have jurisdiction over that issue. Next slide. I don't know if it's on my end, but I'm not seeing the next slide. Maybe my screen froze. Oh, there's one, okay. And I just, last note on Public Law 280 is that we've also had some case law on Public Law 280 from state Supreme Court. And I think that, I don't know if it's on mine, but the text is blocked, or the slide is blocked a bit by the, oh, there we go. Thank you. Okay, so our own state Supreme Court, Washington State Supreme Court, was very clear about the limitations of Public Law 280. And I think they said it really well when they said that in the area of civil regulation, so if we're trying to do any type of regulation on a Indian healthcare provider, by the state, for instance, that would be highly problematic. And you see that they quote, the United States Supreme Court observed that nothing in the text of Public Law 280 addresses the removal of tribal authority, as would be expected if Congress intended such a sweeping change in the status of tribal government. So those are the few slides on tribal jurisdiction. And I know also too, we have quite a few urban Indian health programs, which has different issues there. But I'm really glad that they are on the call as well. But we just wanted to start off just to address a few specific issues on tribal authority. So thank you.
Then, so based on probably 30 years of work by a lot of you all, we were able to put together the Indian Behavioral Health Act. And it really, there was a lot of pushback on the integration of behavioral health payment with physical health payment in the Medicaid system. And I think that really caused us to get down to the nitty-gritty and resolve a lot of problems that the Indian health delivery system was having with the state's crisis care system. And so the things that we couldn't work out programmatically or operationally with DSHS and Healthcare Authority ended up being in this bill. And so it passed. It's kind of right after the stay-at-home order happened, so it was kind of swept under the rug a little bit, but it was a big deal. I won't quote Joe Biden, but it was kind of that level as far as I'm concerned. It was through the work of Senator John McCoy, who has retired now, and I'm glad that we got him his last year, because I don't know if we could have gotten the bill through as easily as we did. It did pass all of the committees in both chambers unanimously, just like the Washington Indian Health Improvement Act. So I just feel like the work that we all did together to create this bill and bring it forward really made the success of that. But now it's passed, and now we got all this work to do to implement it. But so here are the things that are pieces of it that we'll be working on in the next, well, we've already started working on, but we'll be working on in the next few years. So it requires tribal court orders for involuntary treatment admissions to be recognized and honored, which was already in place under Superior Court Civil Rule 82.5, right? And we just put it in this act too, because sometimes it helps to have all the information in one place when people are looking at things. It also allows for tribes to file and or intervene in involuntary treatment admission court proceedings. It requires the notification of the Indian healthcare provider when an involuntary treatment admissions proceedings is happening for a tribal member or a tribal citizen. It allows Indian healthcare providers and tribal courts to receive mental health records. And all of those things weren't happening before, even though the Indian healthcare provider and the tribes have such an investment in the health and especially the behavioral health of their people. And then lastly, but not leastly, it establishes the tribal designated crisis responder. And this is really something we feel will help address a lot of the access barriers that your people are experiencing when they are in crisis. So the DCR will be established through an appointment process with the healthcare authority and the tribe, so that government to government way. And then they will be paid by the healthcare authority to the tribe for the services provided for ITA, and that's still in development, unless we hear differently from Lucy and Jesse today. So again, all this work, the bill passed at the end of March. COVID response was going on, and so we've slowly been turning back to it, but I think we've got a real firm footing on moving forward with it. Next slide, please. So there are slight differences between a non-tribal DCR and a, Aubrey, you're having trouble? Is it advancing on your screen? I'll just keep talking. You'll see when she gets to it. There it goes. So tribal DCRs are similar but different to a non-tribal DCR. And I think the first way we know that is through the appointment process. And as I said, a tribal DCR will be appointed through more of a government-to-government process with the healthcare authority, consulting with the tribe on that. And Heather did develop a attestation form that we sent to the healthcare authority. And there it is. Oh, now your box came up again.
Okay. Oh.
Can you go back?
Is that the slide? Okay. Yep.
Oh. So I'll talk a little bit, just keep talking until she gets the slides up and we'll get to that. Whereas a non-tribal DCR is appointed through whatever the local process is. I think the law says through the local superior court or through a local committee that oversees the behavioral health services. For payment, the payments for the tribal DCR are still under development. I think the funding for those services has all been budgeted out to the MCOs and the ASOs. So if we get something going budget cycle, it will still be a process through them, but not an authorization process, Lucy. And then, for a non-tribal DCR, definitely the payments go through the BHASO or the MCO and the authorization process. So the ASO operates in the way that the regional support network or the behavioral health organization operated previously. The tribe directs the population that is served by the tribal DCR. For a non-tribal DCR, they serve all people in the service area. For a tribal DCR, they follow the revised Code of Washington, RCW, and tribal codes, and that's something we're working on developing. For a non-tribal DCR, they follow the RCW. And for crisis support, we are developing the Tribal Crisis Coordination Hub. And so that will support the tribal DCRs as well as the existing BHASOs and MCO agreements in some areas. And then for non-tribal DCRs, they are supported by local crisis coordination and through behavioral health agencies. So Aubrey, we're on slide 10, if you can get to it. So as I said, there In order to implement the tribal DCR, we drafted an amendment, and I'm going to pass it over to Heather to talk about the amendment and the attestation.
Okay, yes, it looks like we're one more. Yeah, there we go. Thanks. Yes, so we worked on drafting amendments to two particular WACs to make sure that that those WACs included the new language in RCW, basically implementing the Washington Indian Health Improvement Act section, on tribal DCRs, and so it's pretty much verbatim to what's in the Washington Indian Health Improvement Act. And then we also drafted a tribal attestation template. And for many of you on the phone who are familiar with maybe familiar with the tribal attestation process it used to be through DSHS and now is through Department of Health for Indian healthcare providers to be recognized as a behavioral health agency. That's something, that's a model that tribal leaders worked on for many, many years with the DSHS and then DOH. So we thought instead of reinventing the wheel, we'd go back to something that tribal leaders worked really hard on. So we just kind of copied that. And so it's as simple as that, to attest that the DCR meets those requirements that Vicki mentioned on the previous slides. And but another really important part, and I guess we'll see how this works with the Healthcare Authority. I know Lucy's going to talk about it. But a really key component of the attestation is making sure that there's some way that tribal DCRs are on an official Healthcare Authority list. And again, maybe Lucy, you can talk about that, because we need state courts to recognize tribal DCRs. And we've had concerns raised by tribal representatives that when their representatives are in court, or maybe it's an Indian healthcare provider who is providing treatment to a tribal member who is in the state court system, oftentimes state courts are not recognizing those Indian healthcare providers. So we don't want the same thing to happen with tribal DCRs, since they're going to play such a critical component now to serving tribal members who may be in a state court proceeding. And then I don't know if is Lucy going to talk right now about the healthcare authorities work on it?
Hi, this is Lucy.
Kind of, yeah, your sound isn't very good, Lucy. Did you get dropped?
No.
No. Oh, here, because you're a panelist, that's why I can't see it.
And Aubrey, if you wouldn't mind going back to the previous slide that we were on. Oh, okay. That's it. Yeah, thank you.
Can you hear me now?
You're still kind of quiet.
Let me switch to.
Okay. So for the WAC, I think there's a Dear Tribal Leader letter going out soon with the language. Is that correct? Possibly today. Jesse, did I mute Jesse too? I'm a horrible host. Let's see. Maybe he stepped away. No, he's just self-muted. So there will be a Dear Tribal Leader letter going out with the proposed amendment to the WAC that adds the tribal DCR. Aubrey, I don't know if you're able to pull up that Word document. And it was some pretty simple language, just based on the bill, so. Okay. There it is. So, and just as we said, the Washington State Healthcare Authority appoints a tribal designated crisis responder on request and after consultation with one or more federally recognized tribe, or after meeting and conferring with one or more Indian healthcare provider. The rules not apply to counties' independent authority to appoint designated crisis responders in collaboration with tribes under RCW. So there's already a process in place for DCRs, a tribal DCR to be appointed, but then that tribal DCR isn't operating under the authority of the tribe. They're operating under the authority of the county that has appointed them and working either through the BHASO or the MCO. You can stop me, Heather, and take over if you want.
I mean, this document is new to me too, so.
Oh, okay, I can. And then there's the minimum qualifications that we talked about before for tribal any DCR. So, oh, there you are, Lucy. That's better.
I'm sorry to cut you off. I
No.
was just looking at this. It looks like this is the draft that the Healthcare Authority put together. So one of the updates I guess I have for now is that we reviewed the recommendations, and then we also had a small internal work group at the Healthcare Authority that worked on a draft WAC. And so that went through internal review, and we're getting ready to launch that. Hopefully a Dear Tribal Leader letter will be in your mailboxes by the end of the day. Hobita's working on that. That has this language for consideration for tribes to review. And we're giving at least for now a month. We typically do like 2 weeks reviews, but we wanted to give definitely enough time, and then time for everyone to review and provide some comments on the draft WAC. So what Vicki was reviewing was that, and hopefully you'll see some of those things woven through, but it's a little bit longer than I think the other one. But do you want to still look at the ones that you guys recommended first, or?
Oh, Lucy, this is Heather. Well, actually, it looks, so I guess the question is for tribes, as far as a process for tribes to officially have a DCR appointed by the Healthcare Authority. It looks like here, instead of a tribal attestation, like the tribe would submit a letter of recommendation, which seems like that would be even easier than an attestation process, which I think would be great. Is that the case then? And that would be, and then the Healthcare Authority would go through the process of submitting or confirming or verifying the content of the letter.
Yeah, I mean, I think that's kind of where the consultation would come in, and we'd connect with the tribe, and then if you go down, there's quite a bit more details about what would be in the letter. So if you want to scroll down a little bit, that would be great. And then a copy of any policies and procedures that the DCR responder agency that's employing. So that could be tribal agency or non-tribal. Let's see. And then again, the agency certification to provide emergency and voluntary detention services. So this is related to the DOH WACs under like the licensure. So in the attestation world, that would be, or non-attestation world, adding a service to an existing license, or attesting to provide crisis services under the attestation form. And then the next section looks at how DCRs when they're appointed, what information would be provided and how we'd get the information out to, to the ASOs and superior courts. Go ahead and scroll down. So that's the part about issuing like a certification and then getting that information out. And then section 6 looks at what data or what tribal DCRs would submit regarding investigation and hearing data. We're looking at the Crisis Care Coordination Hub for that work. And then, so that's also number 7, having the hub submit that data to the healthcare authority within certain time frames. And then also reporting requirements pertaining to no bed available reports. So if a tribal DCR is not able to find a bed, then that would be reported to the healthcare authority. Also, if there's a single bed certification as well. The next section looks at where a tribal DCR can practice, like Vicki mentioned, anywhere in Washington, but we would typically likely see tribes outlining that in their, I'm assuming that would be outlined by the tribe as well. Section 10, let's see. Looking at how tribal DCRs would coordinate within the regions and in working with the non-tribal entities in the region to coordinate services. And then also just a mention about tribes coordinating with other tribal governments. And that looks like, I think that's the last section.
And that's in the instance that maybe several tribes want to work together on having a tribal DCR or working in coordination with other tribes when they have common patients, which I think probably is going to be more addressed in behavioral health codes. Catherine?
I agree.
Okay, well, I'm glad we have a month. I'm glad we have a month to review those.
Yeah,
It's
again,
really busy this
I
week.
guess, yeah, I guess the biggest update was that this is coming your way. We've done our internal review, so this will be, today the letter will go out, and then it'll also be emailed out to, non-tribal partners or non-tribal stakeholders that will also have some time to comment as well. So
It'll be interesting to see if the BHASOs have any comments, or I know we've been trying to bring them along with this process, but
yeah, it will be really interesting to see that, and that's probably a really good point where we could, we'll hopefully hear back from them, or maybe we need to make sure that they get a notice that they saw it, or to see if they see it come out. So, because I know they've kind of been waiting to check this body of work out and maybe provide comments. So this is exciting.
It is. And we'll be doing more work with the DCR Association. The commission has developed a non-tribal DCR training about the tribal behavioral health crisis system that we're developing. So, and then we'll have more trainings for tribes and tribal leaders too. Okay, next slide. We're to behavioral health codes. So speaking of meetings with tribes, we've met with a few different tribes to really think about the process of having behavioral health codes. So I think Heather's going to talk a little bit about the importance of those codes, and then Catherine's going to talk about the process we go through to try and help think about what are the pieces of those codes and what needs to be included. It's our group think process. Heather.
Thank you. Yeah, and it's been a really great process to work as a team on these codes, and we have experts from different areas, whether, we got Catherine, who has so much expertise in the behavioral health system, and also with the state tribal system, with having her feet in both areas. So that's been really helpful. And then having other tribal attorneys, and then of course Vicki with many years of working in tribal for an Indian healthcare provider. So
and Charlene.
And Charlene, yes, Charlene, who's also has, speaking of having that experience of being in both tribal court settings and state court settings, and also dealing with the state behavioral health system in the Indian health behavioral system, is really critical to informing this work and how we draft the code, the model code. And we say model code, but that's really the wrong terminology, because we understand that we have 29 different nations in our state, and they're all going to have very different laws, different approaches. So it's really more of a starting point for a tribe who has a desire to write a behavioral health code. There aren't many behavioral health codes out there in the nation, which is another reason that we wanted to just have something, a framework to start with. And then also understanding that the interplay between a tribe in Washington state with the state health system has very specific considerations that a tribe in another state may not have. So, and getting back to the first few slides that we did about jurisdiction and authority, oftentimes are confused, and there's an ongoing tension, of course, between tribes and the state, and what the state can do as far as imposing requirements on Indian healthcare providers is a very tricky thing. And I think we just heard that, and how maybe tribal attestation, or how the process might work for the state to appoint a tribal DCR. And so those are just some considerations that we have to take every single time, is what is the extent that the state can impose requirements upon a tribe, and always keeping in mind those fundamental principles of tribal sovereignty. So that's why codes are so important, because these issues are still confusing. There are still many folks who, still on this slide, thank you. There are still many state and local actors, and I'm not necessarily picking on the Healthcare Authority, by the way. There's still state and local still state and local actors who wrongly interpret Public Law 280, or think maybe they have jurisdiction in certain areas when they don't. And the Behavioral Health Code, and I think we lost the slide. I'm still on the same slide with the first slide on behavioral health codes. The Behavioral Health Code is a way for a tribe to really cement their understanding and what is the law of that nation, as far as what they have jurisdiction over and what their authority is. And I think, I don't know, I apologize, I think the slides are next. The Behavioral Health Code slide. Okay, yeah, so this slide, we're still on this slide. Okay, great. So again, the codes are a critical component of tribal self-governance, and not only that, they serve as an extra shield for tribes. If, heaven forbid, they face litigation, and they come before a federal court. Federal courts are going, and state courts for that matter, are going to look at whether a tribe has a code in a particular area when they're trying to determine whether the state has authority or whether a tribe has authority. And a code is just an extra shield for a tribe from unwanted state or local interference, because it makes it very clear that the tribe is the one who regulates in this area, etc. So, and certainly that can be the case with involuntary commitments of tribal members to treatment. And a tribal code allows the tribe, not the state, to declare what their jurisdiction is over their tribal members and over activities on their land. I think we can go to the next slide. And we have developed a table of contents for the Tribal Behavioral Health Code. We've drafted probably, I don't know, Catherine, Vicki, would you say like 60–70% of it? So every week we get a little further with our team of tribal attorneys and consultants and Indian healthcare providers. So again, the first important section of this, beyond, well, the intent section, which Catherine can talk a little bit about, is that establishing what the tribe's authority is, the extent of their jurisdiction, and what their powers are. And the specific treatment approaches, which again would be very different for each tribe, but just having some type of framework where tribes can start with, the role of the tribal designated crisis responder, voluntary treatment, how that works, whether it's on tribal land or off tribal land, involuntary commitment proceedings, of course, and that gets a little bit natty with all the particular legal issues. And Catherine, what did you want to talk a little bit more about the, I know you just worked on the intent section, and I think that's such an important part of this whole code.
Having my unmuting problem.
There we go. Sorry, I have two screens and I moved everybody over to the other screen and then I couldn't actually get to my unmute button. Okay, much better. So yeah, so to kind of give everyone a sense of the intent section, really the idea is to frame it, right? And this is the part that isn't necessarily the word by word code, but it's just the general framing of why is there a behavioral health code. So in our template, we included, we start off with this really kind of foundational big picture concept that is that the tribes do possess the culturally relevant knowledge and expertise to address and enhance health. And we go big with this one. This is some language used in the National Behavioral Health Agenda framework. So we're really trying to encompass that idea that the tribes really do have the expertise and the knowledge and the ability, when sustained properly, to provide this type of care. And that the provision of the code strengthens tribal sovereignty, and that it's about protecting the health and the safety of either tribal members or tribal community members, kind of depending on the tribe. It also clarifies and helps not just with general jurisdiction around health, but also police powers and tribal court orders to kind of help bolster up those, because those are kind of two other key components, especially in the crisis situations. We also though brought in a little bit of the history, that there is a history of disregard or exclusion from care or limited access, and so that's part of why these are coming into play. That it is the tribe's right to step in to cover those failures of that system, and that really it is the code that exemplifies the tribe's strengths and shows resilient, culturally appropriate practices. Then the intent goes into a portion where it talks about the provision of services, because we realize that some services are going to be in-house and some services are going to be contracted for. So it's about kind of the coordination of the services and opening that door to more culturally appropriate practices. So the ability to weave in things like traditional healing, behavioral health aids, to have interventions that address historical trauma, that are resiliency based, that are looking at communities as a whole, and wanting to include that in there as well. And then it breaks down kind of into the two pieces, which is the voluntary side of things and the prevention side of behavioral, and then in certain instances, the involuntary treatment portion. That's the intent section in a nutshell. Which it got a little bigger than some intent sections. So it's out for review from several folks on the team now. I'm sure it will be trimmed down a little bit in the future.
Well, and I think all those points are really relevant too. I mean, this is, you know, something that's really important. It's something that tribes are already doing in some way, but this, as Heather said, you know, helps protect that work that they do. You know, that there was worries that there would be a lot of risk being taken on by choosing to provide crisis behavioral health services, but for the most part, there's already something happening at the tribes and the urban programs. You know, you already have a process in place. This just formalizes it. And so that intent really helps people remember that these are our people that we're taking care of. And while the state and the federal government have responsibilities to help us, we're still the ones that know best how to take care of them. And it kind of brings it back home. And I think that's why the intent section is just so important. And you're doing a great job on it, Catherine. And it, you know, we're Native, it might be long. There might be a lot of words. So that's okay. And, you know, it's a, I don't know, template more than anything, and each tribe can choose to keep what sections and the language and adjust it to meet your own specific needs. But it's just like, you know, a suggestion or like a menu. Like when I cook, I use a recipe I call the guideline because I don't always follow it, but it gives me an idea of what I'm doing. Thank you. So as we've gone along, we've met with, as I said, several different tribes and really tried to start thinking about, okay, so if you have a tribal DCR, what do crisis services look like now at your tribe? And then if you add a tribal designated crisis responder, how will that change? What will that look like? And so Catherine has developed these questions on the next few slides that help us kind of go through that process. And I think it's been really helpful for everybody to really think about, oh, you know, back it up. What about voluntary treatment? You know, we're really deep into the codes and we're like, what about voluntary treatment? That should be at the top. That should be the first thing. So these have been really helpful. Aubrey, if you can go to the next slide, we can kind of go through those. There we go.
Yeah, that's so true that this process has really helped us clarify where things will go into code, because that makes the most sense to have a general call out and kind of a legal standing, and then where things really are more about operations, and would go into maybe an operations manual or an internal policy of some sort. So we started out kind of chronologically. We just talked about the whole process of somebody going through the system, especially if they're in need of tribal DCR services. So we started out with notification, talking about, well, when do folks find out? When does a tribal DCR actually find out? Where does it come from? Who's involved at that point? And I think some key takeaways from several of the tribes that we've talked to so far is that quick and easy access to a central point is really great. So some of them have local crisis lines, some of them would like crisis lines. Their crisis hub would be a great thing, especially even if they needed a local number, but then it got to the crisis hub. A centralized way to find out that something is happening is really important, and that it comes back to the behavioral health program. There are definitely several examples of notification going off in a different direction. So maybe it's law enforcement that is interacting with this person during a crisis situation, and the notice goes elsewhere. It doesn't come back to the behavioral health program. And everyone we talked about is really looking at the tribal behavioral health program being that health home. And so that is kind of one of the foundational concepts around all of these conversations, is that the information comes back to the health home, that there is either a care team approach or at least a specialist who's going to be talking with some other folks with different specialties to really take care of that person. And so looking at notification, recognizing that sometimes it is tribal police or the first responders who are the first folks involved, and the need to get to the tribal DCR right away. So that's the other thing, is that the need to not get bounced around or to not call a third party who then may or may not show up or may or may not go, which is unfortunately some of the cases that we've heard about that have happened using the state system. And so this is the idea is that the tribal DCR really should get notification right away that the behavioral health program in general is involved and knows that information. So the next question we asked folks was kind of around triage. Well, once you get notified, how do you know if it's a regular assessment or if it really has gone to crisis level? And so several of the tribes that we've talked about have talked about kind of internal trainings, trainings for law enforcement, which is really great, trainings for corrections, so the corrections folks are on the same page, as well as the behavioral health program staff, and then coordinating with their medical clinics. So there's kind of a multidisciplinary team approach, some of them truly working together in kind of what you would call an integrated team. And others wanting to just make sure that the coordination is happening, that the communication is getting through to the different pieces. And then I think almost everybody realizes that there's going to be some workflow planning that's needed to figure out all of these pieces, because there's different staff and there's different specialties, and it's going to look a little different at different tribes and different clinics, because people have different bandwidth. And different specialists on staff already, and we just need to take those into account as planning happens. Next slide. The next piece is assessment. So this, we kind of came into questions around, well, you know, how do you know that somebody really needs to be assessed or can't get into a voluntary program? What kind of checks and balances would you have? Because, you know, there could be some political fallout from getting assessed, and we want to recognize that, you know, our tribal communities are small communities, and not let anybody weaponize these processes. And so also, what does it look like to, you know, what do efforts already look like to destigmatize mental health, to get more people feeling like they can get, you know, assessments and know how their mental health is and take stock of it in the voluntary setting, and then where is the difference between a tribal process and the state DCR protocols? And some of the feedback we got was definitely, like I mentioned before, kind of the care team approach, including some first responders and corrections and medical and a few of the other different specialties. Also, that several of the tribes mentioned they do like the Washington State DCR protocols as they're written. So folks that went to the training were kind of like, hey, that makes sense. I can follow that. I know what that is. So it'd probably be something along those lines of looking at how they meet state requirements and following those protocols, but also go the extra mile and are able to provide culturally appropriate services. And then next slide. So then we kind of went along the chronological continuum of, you know, this is happening, this person is being held somewhere, ideally in a hospital with medical oversight, but unfortunately the reality is sometimes they are in jail, and so people are still trying to figure out, like, well, what does that look like and how can we make it the most caring possible? So we looked at transportation, who will transport patients, at what step of the process, when does somebody get transported, when are law enforcement involved? One key thing we want to avoid, we heard this a couple of times, is there have been crunch situations where it ends up being family transporting somebody in crisis. And then, you know, you're scared of them jumping out of the car or trying to run away at when the car stops or something. So we definitely realize that there have been some pretty awful stories and situations, and want to help the tribes figure out the best possible solutions to those, and where to put it in code and where to put it in operations, and help support them in that process. And also recognizing that most of the tribes have talked about some more internal coordination. So there's a need for internal coordination so that the different programs in a tribe know when somebody is in custody, but then also external coordination. You know, when people disappearing in the state system, or if they're taken to a hospital that's off tribal land, not disappearing. So that's a key piece there. And then the next part, the actual involuntary treatment, if that is what it becomes, the situation becomes, looking at, well, what are the protocols? What is the tribal DCR going to do next? How does that fit? And a lot of that actually really fits into the next step, which is going to be referrals and follow-up. So if you want to jump to the next slide, we'll go there because the involuntary treatment part and the role of the tribal DCR, as the several tribes are envisioning it right now, really locks into this piece. And this is this referral and follow-up. That the tribal DCR is involved in every piece of the step, that they know where the person is, that they know what the discharge planning is because they've been involved from the very beginning, that they know, what the plan is, what kind of medications this person is being given, what is happening, what the plan is, because that's the other piece where folks were talking about people getting lost in the system or disappearing. So we had an example where somebody was released with 5 days of medication. Well, the behavioral health program never knew. And so there's no way to follow up with that person to know what's happening. And of course, unfortunately, they're in crisis again. And so we want to keep working on this system of coordination and referral so that as soon as that happens, as soon as the tribal DCR knows, yes, this has gotten to the level where we're going to need to do something involuntarily, that they are able to stay with that patient. And we're really hoping that the crisis hub becomes a piece of this, because the crisis hub will be able to help the tribal DCR track where somebody is, where they're going, what's been happening. And down the road, if there's a second issue, they'll have some of that history as well. They'll know some of the history of some of the clients. So we're looking at that process. And like I said, our conversations with folks have been amazing. It's really, really helpful. Sometimes some of the folks have really got very clear ideas of what they think that's going to happen. Some folks are still brainstorming, they're still trying to brainstorm. And I think one of the hardest things about brainstorming is that people, you get stuck in kind of what are the current realities. And to break out of that and to create some of these codes that really support what could happen, we have to go a little bit further and say, well, what could happen if our programs had sustainable funds and had the mechanism and the process in place, what could we do? And so we're moving into that quite a bit, which is it's really inspiring. So I want to thank everybody that's been having conversations so far. And I'm hoping that, because I'm looking at this list of attendees, and I jotted down some names because I'm hoping that maybe we can have some extra planning conversations, some follow-up coming up this fall and winter with some more folks to get some more ideas on the board.
And we do have some funding this year to do some, just like this, just a meeting with statewide meeting or regional meetings with tribal leaders or partners in the region to talk through some of that coordination or to talk through the tribal specific work. There's a question in a question box. It's a good question too. Does 42 CFR confidentiality of substance use disorder patient records come into play with the information shared today? And it does. That's just like everybody else, we're trying to figure out how that's going to work. Yes.
And we do have a section on sharing of information. Yeah. So we are going to tackle that in this code for sure.
Mm-hmm. And it is, there's, tribal leaders are working at the federal level, just like other, the state and substance use disorder providers on trying to figure that out, because behavioral health integration into physical health is, the way of the future. It's the way of our past, but it's also the way of the future. So our next steps are really to continue working on the behavioral health codes. And like I said, reaching out and doing more trainings in different arenas, the tribal crisis system training to the non-tribal DCRs. We're working on educational material for the court systems, which will be huge because that's been a big stumbling block for years. But we're relying on Catherine's knowledge to kind of help us figure out how they do things there, because it's a different system, different acronyms, whole different language. Are there any other questions? This is just, we just want to show you the work that's going on now and think about what we're going to do in the next 2 years. as our process?
Oh, I did want to add, it's been brought up several times and we definitely have it under consideration is what to do about juvenile mental health.
Oh, that
where to put that in and is it something that can be under this code or is it going to be called out as its own thing? But just to let folks know that is under consideration as well.
Mm-hmm. Does anybody have any comments or questions? Hopefully, I didn't mute you guys again, so you should be able to unmute and ask a question or just type it in the box. Oops, I saw somebody muted. Oh, sorry, Summer. Anybody? Okay, I don't see any other questions.
This is Lucy. I just had a quick comment. I remember, you know, our first meeting where we came together to start kind of prepping and planning this, and I really couldn't. It was really nerve-wracking because I'm like, this is a huge body of work. What did I get myself into?
Right.
Being new to my position, I was brand new too. But it's just really exciting to see all of this being implemented, and just thank you all for your work. I'm excited to see more of these this resource available. So really exciting just knowing where we came from. So
it has been quite a journey. There were a few times that I felt like we were just a little in over our head, but I think with all of the expertise and, you know, pulling from the expertise at Tribes and the Healthcare Authority and then our consultants, I think we've really got it covered.
Yeah, and I think that the work with the tribal centric behavior health, you know, before that David, you know, Reed and the Commission and DSHS and all the other partners worked on in IPAC really set the framework to kind of move this. So although it took a lot of time, it's really great to be at this point. Keep moving forward, lots more work to do.
And I still don't see any new questions. So I just want to say, you know, Lucy mentioned the Tribal Centric Behavioral Health Advisory Board. That's something we're still trying to develop. I know there are several tribes across the state that are building their own facilities, inpatient facilities, secure withdrawal management or behavioral health inpatient facilities. And the Tribal Centric Behavioral Health Advisory Board is still there to help support that work. We're trying to create some regional subcommittees of that advisory board to help kind of coordinate the work across the state. But that would also allow for the board to be able to take advantage of a facility or land that comes up for sale and develop a facility that's statewide or governed by that board. And also the tribal crisis coordination hub, we are still working on developing that. We've sent out the job description and we're trying to hire the coordinator, which is the key position to making the hub work. And you'll be seeing that job announcement coming out again. And if you know of anybody who has looking for somebody with experience working with tribes and understanding the Indian healthcare delivery system, but it couldn't hurt to have a little bit of experience working with the county system and understanding how Medicaid works. But really looking for the right person to fill that position. I thought I saw another question. Now I can't. Oh, we answered that question. Oh, Vicki. Okay. I think that's it. Did I miss a question? We had the 42 CFR question. That was AB. So we're good, I think. Any other comments? Jesse, you've been really quiet. I wonder if he's even actually there. Because I've muted him. I don't know how I keep muting people. It's like some magic I got going on. Okay. So we really appreciate the partnership with everybody who's helped us with this work.
There we go.
There we go. Sorry.
I wasn't able to unmute myself, but Lucy handled it, perfectly.
Okay. Yeah, so we've got more work to do with the Healthcare Authority to figure out the appointment process. Hopefully you all will get that WAC soon and can review it. We'll be reviewing it and giving feedback. And then if you're interested at all in working on the code piece, you can reach out to either me or Catherine or Heather. We have this Thursday morning time slot that we just hold, and whoever shows up, we work on whatever section we're on. It's very casual. But it's gotten us about 2/3 of the way done, I think, with the codes, the template or the model codes, whatever we're going to call them. But I think that's really good work, and it really helps with the really starting to visualize how this can be operationalized. That word I can never say at a tribe, but I think going through that process is really helpful. So thank you. And so far, I don't think we've seen that we need any legislation, which is nice. Take a year off. So if there aren't any questions or comments, we can wrap up unless. So thank you all for listening, and we've got some more sessions this afternoon. We've got the chat program and the MCO performance measures that are both in competition with the governor meeting with tribal leaders, so sorry about that. Don't forget, all of these sessions are being recorded, and Aubrey's getting them up on the website with the slides and any handouts. So if you missed any sessions, you can go back and watch the recording on the website. And then, we're going to be working towards figuring out our work for the next 2 years as a result from the work we're doing here today. I keep saying there's a question and I don't see it. I'm doing something wrong. Oh, okay. Well, that's it then. So thank you all for joining us, and maybe we'll see you this afternoon at some other sessions. But we appreciate your time because we know that everybody's busy. I don't know. Oh, there we go. Oh, good job. Thank you. Give yourself a pat on the back. All right. Have a great day, everybody. Bye.
Take care, everyone.
Thanks, Aubrey.
Bye. Thank you.
Heather, Catherine. Lucy, thanks for helping us out. See y'all soon, I'm sure.